work. Okay. Well, the network is important. You are an expert center, and we have the ambitions in Paris to be an expert center. But of course, we have to have a network of physicians aware of the disease, and to don't spare a lot of information. And we have, however, we need to have a centralization of the expertise in our country. We need to have a kind of centralization of data, and we need to have cooperation first at national level. I think I am playing for strong national groups, and also to have international cooperation. We need to have a good science, and there is plenty of questions to answer. We have to have efficient drug and good schedule, and maybe we have a good drug, but we don't know how to use it. And we have also access to the drugs. And of course, you know, you are between, I think, the well-funded country like France and the US, but and between the third world. But I think we know that the access to the drug of the new drug is very costly, and it represents a challenge for many countries, and also for the kids. And so this is the background, I think, of all what we can propose today. Next up, a few words about the family of disorder named Histiocitosis. And next, so Histiocitosis is a family of disorder with histiocyte in the tissue. We may have malignant histiocitosis, like acute myeloid leukemia type 5 is a kind of, can be a monoblastic infiltration is a kind of histiocitosis. We may have a chronic myelomonocytic leukemia in adult or in children, which is a kind of histiocitosis. We may have a true malignant histiocitosis. We may have secondary histiocitosis, not clonal, like in metabolic disease, like a Gaucher or Niemann-Pick, or reactional, like in cancer. You may have a histiocyte around cancer cells. In Hodgkin disease, sometimes we have lymphohistiocytosis. We have post-infectious histiocytosis, like in tuberculosis. And we have primitive histiocytosis, clonal but not proliferative, Langerhans cell or non-Langerhans cell histiocytosis. Next slide. So today I will just talk about the red diagnosis, and mainly the primitive histiocytosis, and mainly the Langerhans cell histiocytosis, because it's a most frequent one. But in the practice, we make differential diagnosis with many other kind of histiocytosis, and it is always a challenge to have a good diagnosis before treating a patient. And so we spend a lot of time to find the good diagnosis, and we need pathologists, we need clinical expertise, and we need all this confrontation to make the good diagnosis. Next slide. So the revised classification we used was published now about 5 years ago, with the L group, which belong to which encompass the LCH, Erdheim-Chester disease. The C group is a kind of cutaneous non-LCH, like juvenile xanthogranuloma. The R group is Rosai-Dorfman. The M group is a malignant histiocytosis, and the H group is out of the family somewhere. Is a primary HLH, which is a genetic disease with histiocytosis involved, but as a consequence of the primary deficiency, and not really as a starting cause. So next, so we discuss a second point important to have in mind is the macrophage ontogeny and the mitogen activated protein kinase pathway. Next slide. In our mind, we start with this concept. Monocytes are coming from the bone marrow, and they are going to the tissue, and in case of stimulation, they are going in the draining lymph node and contribute to the primary immune response and to stimulate the lymphocyte. That's a simple view. We know that now it's more complex. Next slide. And the ontogeny of macrophage have two waves in the body. One wave is very primitive, is coming from the yolk sac. And this wave in green in this slide may colonize the different tissue, like the microglia in the brain, and also in the skin, there is a dual origin. And after the first wave, so the first what we call resident macrophage, we have a second wave coming from the fetal liver, which is probably in the blood the most simple group of cells of macrophage, easy to find in blue. And it colonizes also some different organs. But we have to have in mind that the embryogeny of this macrophage is dual. Next slide. What about the MAP kinase pathway? It's a very important pathway to communicate between the membrane of the cell and the nuclei, and to trigger the activation of the cell. And we are, next slide, interested by this central pathway, which is the MAP kinase pathway from the RAS, RAF, MEK, MAP, ERK. That's a very central pathway now involved in LCH. Next slide. And discovering this pathway offers the possibility to use a MAP kinase inhibitor, which can be BRAF inhibitor like vemurafenib, dabrafenib, encorafenib, or ERK/MEK inhibitor like COBI, TRAMA, binitemib, or selumetinib. So there is two we have to have in mind, because we will discuss of this further. Next slide. What about LCH itself? Many of you know pretty well what I'm going to present, but however, it's a recall. I will be short. First, the LCH diagnosis criteria is both the association of a pathological proof of LCH with histiocyte accumulation in the tissue, but also a clinical radiological symptoms. Both the two clinical and pathological confrontation should be present for the diagnosis. We have to have in mind that in a tissue with LCH, in a granuloma with LCH, there is very few histiocytes. It's not like Ewing sarcoma, or I don't know, leukemia, where there is almost 100% of pathological cell. You may have only 1, 2, or sometimes more, but you may have very few histiocytes in a granuloma. And so it's the pathology is not so easy, and the molecular studies are not so easy because of this limited number of pathological cells in the granuloma. And moreover, with time, if you make the biopsy with some delay, you may have an evolution with a lack of expression of CD1A, for example, and what we pathological in French is xanthomisation, in Spanish, I don't know. In English, xanthomization of the cell. And so with time, this granuloma may change its aspect, and the diagnosis may be difficult if you delay the time of the biopsy. So next time. The epidemiology, we have now a register with about 3,000 patients in France, and clearly it's for us a disease of the very young children, and the disease, the distribution by age is very asymmetric. Most of the patients are babies or very young children. Next slide. But with this curve, I put by epidemiology, the medical needs. If we look to the number of patients who may need special targeted therapy, you have the babies, you have some young adult, and you have adult after age of 60. That's what we have observed in France. So in a country like France, like 65 million inhabitants, we have 11 million of children, and we have about no more than 15 new indication of targeted therapy. So we are dealing with extreme rare situation, and moreover with very different age of presentation. So it's a very complex to manage this without a network. Next slide. So few words about the clinical presentation. Next. So many organs can be involved, as everybody know. Bone, skin. Bone is the most frequent one. Skin, about a third of the patient. Lung in 12%. Pituitary, and so we need to have an endocrinologist. I don't know, she's here, but we need constantly an endocrinologist for managing this patient. In 5 patients, we have central nervous system, and only 15% of the patients have a systemic involvement. Next, so some slide. So the typical bone lesion of the skull. Next, you have this hole in the skull with a soft tissue infiltration. Next, you may have, well, in this three-dimensional CT scan, like a hole, but of course it's not a hole. It's a less calcification in some part. Next slide. We have some vertebral crushed, so vertebra plana. Next slide. We have a skin infiltration like with erythema and squamous. Where in a baby like 18 months old. But next slide. Like in it can be found at birth, and it looks like your baby. So the first minutes of life, you may find the diagnosis of LCH. Next slide. And you may have a risk organ, and risk organ in the world of LCH is patient with liver, spleen, or hematological dysfunction. You have this only slide of this this picture of this baby with a huge abdomen with hepatosplenomegaly. Usually such babies have skin involvement, no bone involvement, and it's a life-threatening presentation for everybody. Next slide. What about CNS involvement? There is 2 types, mass lesion of neurodegeneration. Next slide. Mass lesion is very easy to detect. There is usually some symptoms according to the localization. And but you may have some diffuse tumor, CNS mass lesion like metastasis, or you may have a single lesion central at the axis of hypophysis axis. Next slide. And you have the neurodegeneration. And neurodegeneration is a nightmare, I think, for people who take care of patients with LCH. It is late after the onset of LCH, after a free interval usually. You may have cerebellar symptoms, cognitive limitation, or pyramidal syndrome. If you make a biopsy of this of the brain, you may have just neuronal loss, and so sometimes it's too late. You just have the desert. You don't know exactly what was the fight, but there is a desert with no more neuron, and the typical lesion is on the MRI. With this hypersynal of the Donnadieu nucleus of the cerebellum. Next slide. Lung involvement. You may have the key examination is the CT scan, because the symptoms can be limited. You may have no symptoms or just dyspnea in case of pneumothorax. You may have some nodules on the CT scan. You may have cyst. Next slide. Next. Such a massive cyst can also be life-threatening, and the patient was transplanted for the lung, and you have the aspect of the lung on the right. Next slide. And last aspect is very specific to children, I think, is a condensation, and it was like your case, Guido, or Julia, I think, where there is condensation like a pneumonitis in a patient with present risk organ involvement. Liver involvement is important. You may have acute and probably inflammatory one, and you may have a chronic. And this paper, I cannot show you the paper, but it's a paper for Jorge, because the Garrahan has published a lot of in this thema. you may have such a chronic involvement, which is difficult to understand exactly why you have this specific involvement in this disease with the duct, a biliary duct fibrosis, which can be found on the cholangiography or MRI, and that's a biopsy on the top above on the right, where there is a kind of onion infiltration of the biliary duct, and we understand that it was difficult to have a good elimination of the biliary. Next, and other involvement like a node and tibus. So next, globally, if you look to the presentation of the LCH, and it is driven by age, you have in newborn skin and multi-system in LCH. In teenage, in older babies, you have recurrent LCH with DI and sometimes CNS neurodegeneration with bone involvement. In teenager or young adult, you have lung involvement very frequently. Above age of 30, you have LCH, we may be associated with Erdheim-Chester disease. Next slide. So I think I need to have maybe a water. And maybe I hope it's not too speed for you. So second thing, what about the therapy till 2010? 2010 is a very important year in LCH. I will explain why. What we know is that about in half of the case, nothing can be proposed to the patient because the disease is self-regressive, and sometimes the patient just need a local therapy because of the pain, because of the bone involvement, and there is a great choice of therapy. But the validated scheme is associated in first-line therapy, vinblastine, steroid, and 6-MP, at least for 1 year. There is a discussion and a protocol about randomization 1 versus 2 years, but what is accepted now is at least 1 year. And in second line, you have 2 drugs important till 2010 is 2-CDA and 2-CDA with RSC. Next slide. Just to recall that vinblastine was the first publication was in 1963, so more than 60 years ago, and December 1963. That's the first use of vinblastine. So it's a very old drug and safe for the children who may grow up with this treatment without risk of leukemia, without risk for the fertility. So it's a good drug for LCH if we just can use it. Second slide. It's on the same topic. Next slide. Sorry. You may see that's more about the formula of vinblastine. And this young woman it was I find on the internet. Smooth seas do not make skillful sailor. And probably this young woman have used a lot of vinblastine to be in good shape. And the vinblastine is derived from the periwinkle from Madagascar. So it's kind of tisane, a kind of mate. Okay, next. And with the addition of 2-CDA and 2-CDA-RSA, just the survival curve before the MAP kinase inhibitor. I take the French survey. We published this in British Journal of Hemato with about 1,500 patients. And we just observe with the use of 2-CDA-RSA a progress in the survival. And in 2010, we have this survival rate, that's a red curve, so upper and red. For all the patients, the first survival is about 99% of survival, and it has been progressed thanks to 2-CDA-RSA, and the 2-CDA-RSA has made progress in patients with risk organ in LCH. So just given 2-CDA-RSA in the little group of about 15% of the patient with risk organ, you increase the survival of the patient. So for oncologists, such curve is good enough, I think. But we are not satisfied, however, and we can, next slide, we want to do more. And we want to do more because there is a toxicity of the drug, and because there is reactivation, and because this approach is not able to control the late effect of the disease. The toxicity is mild with vinblastine. It's just a day hospital appointment, which is not really fun, but however, it's not a big toxicity. It's moderate when you use 2-CDA. It's a major if we want to, we need to use 2-CDA and RSA. And there is about still 10% of toxic deaths with 2-CDA RSA. It is probably the same with clofarabine. So there is some limit in the toxicity, in the therapy. Next slide. And the most important limit is a permanent consequence, which historically represent 30% of the patient, with some pituitary dysfunction in about 20% of the patient. So again, there is a strong need to be associated with an endocrinologist. We have skin scare, bone deformation, deafness, but we have neurodegeneration. In the percentage varies among the series between 1 and 5%. We have liver failure, and we have also respiratory insufficiency. Next slide. So the medical needs at this time can be summarized in this way. We need a non-aggressive way to control the disease. We need to treat the sequela. We need to prevent the sequela, and we need to break the recurrence. That's the objective we have. Next. And MAP kinase inhibitor. Next. There is a BRAF revolution in 2010. And the BRAF revolution was thanks to this guy. The name of this guy is Barrett Rollins in Boston, in the Dana-Farber. And at the moment he started his study, probably nobody in the world of LCH thinks that it is a kind of clonal disease, really. And he just built a ship with about 100 genes and about 1,000 mutations, and check on the biopsy of LCH if there is such mutation. And the big surprise is that he found that half of the patients with LCH have this BRAF V600E mutation. And so that's the BRAF mutation, which is, next slide, the Barrett-Rollins revolution, because since now, all the works in the LCH are around this question. And he had opened a gate for LCH with this work. The next slide. Now we know that about 50% of LCH have a somatic BRAF mutation. We know also that about 100% of the patients with LCH present a ERK activation. So downstream of the BRAF pathway and the MAP kinase pathway, phospho-ERK is, if it is stained, it is activated. And now we have almost all the mutation in all patients. If we have, we use different techniques, it's possible to find about 100% of mutation of the MAP kinase pathway in LCH. Next slide. There is a question: is do the presence of a clonal mutation is put LCH as a cancer or not a cancer? And I cite again Jorge. Well, we know that even if it's a clonal disease, LCH, the Langerhans cell do not proliferate. There is no local extension, there is no metastasis, and there is about 50% of auto-resolution. So the phenotype of LCH is not a cancer, but however, this disease is clonal. Next slide. And what this changed is that the BRAF V600E is associated with some bad prognostic feature in LCH. And we have published this in GCO, and the conclusions are here. Next slide. We know that LCH, BRAF V600E mutation is associated with young age, risk organ, poor response to standard therapy, And about 98% of BRAF V600E is mutated if you have blood and skin involvement, is associated with inflammation, is associated with high rate of sequela. And of course, it's not it's a risk factor. It's a statistical risk factor. It's not the cause, but it's a very important risk factor. Next slide. It has been also recently confirmed by the Netherlands team with Astrid and Paul Kemp. So next slide. And what also is important of BRAF V600E is this this mutation is associated with the neurodegeneration. And it opened also a gate to understand this neurodegeneration. We know that in the past, the real risk factor of neurodegeneration is the presence of pituitary involvement. If you have no pituitary involvement, you have less than 1% of neurodegeneration. But if you have a pituitary involvement, you have about 13% of neurodegeneration. If you add the risk of what we call bone base skull involvement of bone and DI, you have 0 versus about 8%. But if you have taken consideration the BRAF mutation, you have about 30% of risk of LCA of neurodegeneration, and in association with other factors, meaning that if you take in consideration the clinical extension of the disease and the BRAF status, you may detect a group of patients who have about 1/3% of risk of neurodegeneration. And it's also important for the management of the patient. Next slide. Now, sorry, I was long for the preliminary. Now we are speaking of the targeted therapy. And so this is a recent story because we start this since no more than 13 years ago. Next slide. We benefit of this possibility of therapy, which has not developed for LCH, but which has been developed for cancer. Next slide. And our concern when we know the BRAF mutation is that targeted therapy has developed for adult cancer. And some side effect has been observed, for example, in melanoma, which are very worrying. If you use vemurafenib in BRAF V600E melanoma, the risk of secondary cancer, and the name of this secondary cancer is acanthosis, is about 1/3. So adults treated by vemurafenib for melanoma have 1/3 of secondary cancer. And so it cannot be acceptable for children. And so we are worrying about this. We know also that the demography of medical need in LCH is very different compared to adult cancer, because we treat very young baby, and it's not the same to treat adult at 55 years old or a baby at birth. We don't know about anything about the pharmacology in baby. We are very careful for the rest of the life of the baby. And in addition, we have no company support. Next slide. We start with this, the adult story with my colleague Julien Roche in Paris, who published 3 cases of Erdheim-Chester disease treated with BRAF mutated, treated with vemurafenib. Next slide. And what it is surprising in these first 3 cases, the patient with Erdheim-Chester disease have a mixed disease. Somewhere in the body, it's Erdheim-Chester, and somewhere in the body is LCH. And when you give BRAF inhibitor, everything go down, everything recover, both the LCH and the Erdheim-Chester aspect. So based on this, we have the idea to treat children patient. We are very careful. Next slide. And so that's the first season. The season starts in 2010 and finished in 2019. Next, we first define some target group. So I have already said that before. We evaluate pharmacokinetic when we provide the drug to the baby. We try one drug after another one, and we know that company, even they are not supporting you, they are making some advertisement to give any new targeted therapy, but we stay on Vemu for this reason, because it was the first published in melanoma, and there is the drug with the most larger background, and we try to we obtain an orphan designation from the European Commission, but we give the drug off-label. And next slide. We publish the first cases in JAMA Onco. Next slide. And I will much more comment this publication in GCO. We have published 54 cases in 2019. In this survey, next, we select only patients. We take in consideration only patients with refractory disease. And all patients are refractory to vinblastine steroid. And a lot are refractory in addition to 2-CDA, 2-CDRSA, clofarabine, and vancomycin RSA. So we take in consideration only the worst case, whatever the patient is risk organ positive or not, but it should be refractory. And usually when you became refractory to 2-line or 3-line of therapy, it's not good. Next slide. But the result was extremely good, and it was a big surprise for us. About 2/3 of the patients have this. This is a waterfall presentation. About 2/3 of the patient was in complete remission after 8 weeks of treatment, and a third of the patient have a good partial response. So there is overall good response in all patients treated by vemurafenib, monotherapy for this group of patients. So it was a first good clinical results. Next slide. Just to show you this young baby with a massive node at day 1, and there is no nodes at day 14. So it works. Next. And the overall survival was 99%. So we observed 1 death. And so it's considering the poor prognosis of this refractory group of patients, it's not so, it was extremely good, I think. Next. And the adverse event is mild. We mainly observe skin rash and photosensitivity. This is dose dependent, and it's clearly less than high dose chemotherapy. At this time, the sole death observed was a death observed in a patient who was receiving clofarabine and vemurafenib together. And we think that it was not a good idea to associate the 2 drugs. Next slide. Well, if you want to have more detail about the skin rash, we have a publication on this. Next. Well, maybe one question. One very important point is that there is no secondary skin cancer, contrary to what has been observed in adults with melanoma. Probably the skin of the baby is better, or there is no clonal event on the skin of the baby, and there is no secondary cancer in this group of patients. Next. The pharmacokinetic is interesting because we crush the pill, which is not probably the good way or the best way to do it for the company, but that's what we have in our hand. And crushing the pill, and even if the patient have hypoalbuminemia, next slide, we can demonstrate that at day 14 there is a steady state of the drug. And we can define a therapeutic zone between 10 milligram and 30 milligram per liters. And we can say also that we achieve a toxic dose if the dose is above 50 milligrams per liters. So the pharmacokinetic is show us that the drug is absorbed even in children, in babies. Next slide. The main problem at this time was a reactivation rate when we stop the treatment. And this is the survival, the risk of reactivation after the therapeutic stop, at about more than 80% of the patient, when you stop the treatment, reactivate. So, so it was not a good news for this therapy, and we need to provide this therapy in a long-term fashion. Next step. And one explanation of this reactivation rate is the drop, but not the elimination of the clone, the BRAF clone. So with the targeted therapy, you decrease the BRAF load in the blood, but you are not eradicating this clone. Next slide. And if you correlate both the reactivation rate and the BRAF load, if you have no, if you still have a BRAF load positive in the blood during the follow-up and you stop the treatment, you have almost 100% of reactivation. If not, we have not observed reactivation. Next slide. And a few words about a very complex slide about the different way to try to stop the treatment. Because we know that the reactivation at the stop of monotherapy is important. Several colleagues tried to propose different approach. And the different approach was association of VEMU with COBI, with VEMU with vinblastine corticoid, with transplantation, with vinblastine steroid. There is different ways. None is working. So you can summarize this slide. Despite this huge effort to find a association treatment, we have not found it. Next slide. So at this time in 2019, we know that despite a short follow-up, the treatment is globally working. But the reactivation at the therapy withdrawn is important, and there is no clone eradication. Next slide. A few words about other indication. For neurodegeneration, there is no clear data. It's not the same as a primary LCH, active LCH. For sclerosing cholangitis, most of the patients who have this indication did not recover of this liver infiltration. For lung involvement, we have some good, not for all, but some good response. Next slide. Just to show you this case report, it's a 18 months baby with skin and lung involvement, no other risk organ involvement. He had this CT scan, and so you may imagine that it's not in a perfect health. He had a rhinovirus infection, which dropped him in intensive care with artificial ventilation. Next step. And that's the CT scan after 8 months of vemurafemib. So there is not a very quick improvement. But this baby who was BRAF mutated, who have a lung involvement, have a recovery of the lung anatomically. And it was a big surprise for us. And I think because we suppose that cyst cannot be, it's a destruction of the lung. And given a BRAF inhibitor, we observe a kind of a cure of the lung destruction. And so it's complex to interpret, but we have this good news also. Next slide. So season 1, that the conclusion was a short-term efficiency in refractory LCH, some efficacy in lung LCH, and evaluation should be done in neurodegenerative LCH. Maybe I can propose, you are not sleeping? No, because we now go to the season 2, which is now since 2019, long-term outcome and other indication. If we want to find the solution, I think we need to have a more card in our hand, and the game became to be complex. We need to have biological markers. We need to have a clear therapeutic schedule, and we need to exactly to know the target, the disease target in terms of the clinical aim, and we need to have a pharmacokinetic information and many things. Next slide. Despite the complexity, we know that there is no company support, and they accept probably to provide the drug not for free, but they accept to provide the drug, but they are not interested by this topic. We know that because of these good results, many physicians will treat with this drug, and so we have proposed to evaluate this in a multi-center approach, and we say in EU and other country. Other country is Argentina. Because we with Guido, with Jorge, we connect, and such Argentinian case has been joined to this EU country. And we know that so we built this international project. I can go through this. And next. Okay, and so the results now is about 228 patients. Most of them are LCH, 212, but we have one patient, one children with Erdheim-Chester, where 6 Rosay-Dorfman, 5 XGXG, and 3 malignant histiocitosis. The median age of this group of patients is 1 year and 3. So it's a very pediatric population. Most of the patients with LCH have BRAF mutation, and in other disease, there is most of them have other mutation. Next step. So that's the country who have participated to this survey. So a lot. We have now 16 countries. So it's complex to collect the information from everywhere. Next, and to go to the result, it's very busy, but in short, in LCH, we at short term observe a good result, but we have some partial response in 6 out of 120 with the refractory risk organ patient. So at first evaluation, it looks very good for every patient, but we know that in some patients, even with the good therapeutic approach, we have not a good response at first. In a risk organ negative refractory patient, we have almost all complete response. In lung involvement, we have partial response or complete response in 8, but we have failure in 4. So about 2/3 of good response. In neurodegeneration, we have, however, with time, partial response in 20. So it's not so bad. And the main question for the neurodegeneration is the tolerance of the treatment. And many patients, because they need treatment for a long-term fashion, are not supporting this treatment, and they have to withdraw it. Sclerosing cholangitis, 7 patients, 7 failure. Other like diabetes insipidus, 2 and 2 failure. In Erdheim-Chester, complete response in 1 out of 1. In Rosay-Dorfman, we have 1 failure in a patient with SLC 29A3, which is a kind of the Fezalabad syndrome. I don't know if you know it or have seen it, but it was not a good indication, but the other indication was good. In xanthogranuloma, 5 good response. And in malignant histiocitosis, none of the patients have a good response. So next, it's with regard to the side effect, the side effects are almost photosensitivity in 80% of the patients with VMU, less with DABRA. We have some severe side effects with retinitis, uveitis, with DABRA, VMU, or COBI. We have myocardiopathy, and we have 3 deaths under a MAP kinase inhibitor, but it appears mainly related to chemotherapy or to the drug itself. If we develop a little about the deaths, where overall we have 7 deaths, but only 3 under treatment. And in the 7 deaths, we have the malignant histiocitosis. We have also a neurodegeneration after the end of treatment of MAP kinase inhibitor. Next. One important topic for us is the observation in the patient who have, so that's the case for the first patient you present at the beginning. Patients who have no neurodegeneration, who have been refractory to LCH and treated with with MAP kinase inhibitor. And among this 166 patients, 30 has systematic MRI, routine MRI. And the observation we observe is 15 out of 30 patients who have an MRI, a systematic MRI, have neurodegenerative symptoms. Next slide. So if you look to the observation, the risk curve of this neurodegeneration, the MRI neurodegeneration in patients treated with risk organ by MAP kinase inhibitor, it's with time, more than 6 years after the start of treatment, you have about, in this evaluation, about 100% of neurodegeneration. And it was an extremely bad news to observe this, because we have the feeling, and I hope it's not the case for your kids, but we have the feeling that the systematic disease is controlled by MAP kinase inhibitor, but the CNS is not controlled. And so next. Next, I just give you some, you are not too tired? No, I can just, okay. We treat this patient with LCH diagnosis at birth. Next slide. And this patient have LCH at birth. At day 10, she had presented anemia, albuminemia, hypoalbuminemia, and anemia. And so we have also liver and spleen extension. And the MRI at month 1 was normal. Next. That's a summary of the treatment since birth. We start with just a supportive treatment. At this time, we are a little shy, and we propose first steroid at birth. At day 10, we don't want to treat with targeted therapy at day 10. Then we try 4 pulses of steroid, venlafaxine, sorry, but there is a disease progression. And at day 50, we start the vemurafemib. And this is the BRAF load, and the BRAF load remain positive during all the treatment. And we try for 2 years at the beginning, VEMU, and we stop VEMU, and in 2 weeks, there is a reactivation. And at the time of the reactivation, the BRAF load increase, and so we start again vemurafemib. And we start for about 1.5 years. And after 1.5 years, we say, well, the baby is fine and grow up. We try to tape down the dose of VEMU, and hoping to like in CML, we try to tape down. But at the time when we decide to stop VEMU, we perform an MRI, and next step. And on the MRI, so performed at age of 4 years, 6 months, we have this bad news. We discover that there is a massive cerebellar infiltration, and we say there is a neurodegeneration without doubt. And also, when we look to the baby, while she's at the end of the kindergarten, and she's a little clumsy, the parents complain of weakness, but the symptoms are limited, and she's able to read, to write, to draw. So it's not complete. And next. What we have done, we decide to increase the dose of VMU, and because of a skin rash, we switch to DABRA. Good. Next slide. And the good news is the last evaluation after 1 year of this treatment. So after 1 year of resuming at high dose, the MRI improved, and this little girl now have no more fatigue, no more falls, and she progressed in coordination. She started the first year of school without problem. So we have the feeling that maybe we can control the neurodegeneration if we increase the dose of targeted therapy. Because the main challenge is what is a part of the systemic drug with achieving the brain, and so that's a big story for the big issue for the next period, I think. Next slide. I say maybe the neurodegeneration observed in this group of patients is a question of dose. Next. Myelodysplasia. Again, your patient and the patient in Norway have presented a myelodysplasia. I will make this next slide. This case is almost look like a case published by the St. Jude group after DABRA, but the patient with who have this myelodysplasia with monosomy 7, with, of course, LCH and risk organ patient, have developed this after receiving clofarabine, VP16, Aracid, 2-CDA. And it is also the same history of a patient from the Russian group who have presented among 19 patients a secondary myelodysplasia. And overall, if we add our experience and what is published and what is known, the 4 patients who have myelodysplasia represent 4 among 55 patients who have received high dose of chemotherapy, while no malignancy has been observed in a patient who have treated with targeted therapy alone. I don't know if the statistic is significant, but we have the feeling that we don't want to give a lot of chemotherapy together. Next. So there is a lot of discussion of the therapeutic, of the how to stop. Is there a stopping plan for the targeted therapy in LCH? I will not develop a lot, and just to give some information. Next. About transplantation. We have 3 transplantation indicated to stop to eradicate the BRAF clone. And unfortunately, in the 3 cases, there is a persistence of the clone after transplantation. I don't know if this result is enough to consider that we want to try again or try more, but it's not very suggestive that a transplantation is able to eradicate the clone. Next. And so AML and the possibility of lack of eradication is a big question. Next. So the long-term option, and I will probably finish around this. Presently, the only recommendation is try to stop and resume its reactivation. MAP kinase alone is not a poor issue. It's not a poor option, I think. But low dose of MAP kinase inhibitor arise a problem of neurodegeneration. The association of chemo is still probably in evaluation, and we have not the response. And next. And to finish, I hope maybe I have not exhausted you. This result, the clinical result, suggests a big question: where is the reservoir of the 2-CDA, of the BRAF clone of the LCH? So because we have a very clear, very nice response with this therapy, but patients have even BRAF load in the blood, but we don't know where is the clone. And that's a stimulation for many research. I will cite two papers. One is a paper from the UK group in the blood advance. And what they have observed, which is funny, that at the beginning of the disease, the BRAF cells are myeloid. And with time, there is like a switch between myeloid cells to lymphoid T cells, BRAF. And so that in red, it's a myeloid. If you look in detail the paper, you will see the red circle are myeloid cells, and the dark, the black are T cell. And so at the beginning in the blood, you have myeloid cell with BRAF mutation. With the follow-up of the patient with treated by BRAF inhibitor, you have T cell. So it's something difficult to understand because this cross lineage is it's a mystery, I think. And the second hypothesis is a hypothesis of the Geisman group, where they are looking to the macrophage resident. And they say that, well, they have animal models, and now they have also some human model showing that the myeloid, the microglia cells in the brain are coming from the yolk sac. And so you may have an animal model which summarize somewhere the histiocitosis with neurodegeneration. And you have this aspect in a human. So maybe one of the reservoir of the LCH can be the resident cell, which can be mutated, which suppose that the mutation is probably very early in life. And it may explain why it should be very difficult to eradicate this clone, because you have a baby with a very premature LCH in the life, will have this clone for life. Next step. So the conclusion about LCH is, well, biological knowledge have strongly changed our mind about the conception of the disease, have opened the gate for therapy, and long-term control of the disease is a challenge, and we still have a need of cooperation. And if you are not too tired, I will finish with two case reports about the input of molecular anomaly in the understanding of GHG, the xanthogranuloma, so non-LCH, and the use of targeted therapy. I will start with next. Well, that's a presentation. So GHG is usually a skin disease with this yellow papules. There is ERK activation. The molecular background usually is not BRAF V600E, but other gene. And there is some systemic disease. Next is a paper from you. So you have treated one patient with a extremely poor, well, the name is progressive nodular histiocitosis with cobimetamine. The success was not on-off, contrary to what we observe in LCH, but that's the best way to control the disease for this baby, or this young children, but with a very chronic disease. And so it was, I think, a good, maybe the first example for a non-LCH. So thanks to your report. And next, we have also another surprise is ALK mutation in GHG or in non-LCH mutation. Next. And just look to this patient. We have something which look like your patient. It's a big nodules on the skin at birth, yellow. The skin biopsy show GHG, and the NGS and RNA-seq, because we know that we have to look for that, show ALK mutation, ALK transcript. And we make abdomen evaluation and test X-ray. And at birth, he had a little, he had a normal abdomen X-ray, abdomen ultrasound, so liver and spleen was normal. Chest X-ray was just showing a little round lesion. But at month 3, there is skin massive infiltration, and moreover, the X-ray and the abdomen ultrasound show a progression with a pleural infiltration and a kidney infiltration at month 3. Next, look to this situation at month 5. So there is a massive papules on the temporal lesion, and so there is the same on the abdomen and the same on the thorax. And at this date, we decided to treat with a classic treatment with vendasin steroid and 6-MP, but there is no effect. Moreover, at after 3 weeks, the lesions are ulcerative and there is a pulmonary embolism. And we use at this time crizotinib. And next, and you see the contrary to the nodular histiocitosis, there is a very dramatic response of the skin. So the situation at day 0, day 5, day 14, and months 2.5. So almost disappearance. And of course, inside it's the same, and maybe a few of the scan. So molecular offer the key of different diseases which are otherwise extremely worrying. Next, so that's the day 14 CT scan. So that's just one example, and the last example is a 4-year-old girl with pancytopenia, considered as aplastic anemia. But on the bone marrow trephine, we were surprised to see few histiocytes. And they have a bad shape, but Jean-François Emile looked to this, which our expert, and performed MGS at this time. He said, no, there is no mutation. He said, okay. The patient, next slide, go to transplantation. He had a transplantation for aplastic anemia. And next, but after the transplant, there is persistent pancytopenia. And we try to use romiplastin for increasing the platelet. We switch cyclosporine to tacrolimus. And moreover, on the chimerism, there is a loss of the graft, and there is some skin lesion which appear. Next. And this skin lesion has been biopsy again, and it was GLG. We said, wow, we missed GLG at the beginning. And what we have observed, the few cells in the bone marrow was somewhere GLG. And the RNA-seq find the solution, and we find a transcript of GLUL FTL23, which is something I don't know before. And well, we say, okay, there is this, and we go back to the bone marrow at the beginning, and this was present. And next slide, we use sorafenib, and with sorafenib, the graft disappear, but there is a normal blood count, and all the involvement of this GAG disappear. And so it's also a good lesson, looking at we need to have this molecular study to help us to treat the patient. And so next, that's the real conclusion. Histiocitosis is a clonal MAP kinase disease. In LCH, the classic therapy is useful for most of the patients, but when there is a poor response, we have to think to MAP kinase inhibitor. And in other LCH, also histiocitosis is also important. Thank you.
Thank you very much, John, for your very nice and interesting presentation. I would like to ask you if you remember what were the molecules of MAP kinase inhibitors for malignant lung cell histocytosis, the 3 cases that you showed. No, but because we have one patient recently, which did not respond initially and was treated, was BRAF negative, BRAF B600 negative, and we began treatment with trametinib, and he's doing well 3 weeks after the beginning of the. Well, it was.
The malignant histiocitosis is much more heterogeneous than we imagine. And we have some secondary malignant histiocitosis after lymphoma or leukemia. And we have primitive malignant histiocitosis, and probably it's not the same. And yes, we have some patients with clonal evolution.
Yes, our patient was a case after a T lymphoblastic leukemia, and has a molecular finding, which is a clonal identity from, and there was a. Yes, that's it. And there was a mutation in the cyclin in. Yes, but it was present in. It was also present in the lung cell malignant cells. So the question was is if we could use cyclin inhibitors to treat this case eventually.
Well, even with the 3 cases, the 3 poor response we report, we have our other case we treated in this way in France, because we in such disease which is extremely poor prognostic disease, we have no solution. And maybe if you have a, well, yes, it's allowed, of course, because we have no, yes, maybe it's if it may work, you are lucky. I mean, if you are, yeah, no, we it's not a definitive, and also the each case maybe have some specificity, and yeah, so it's absolutely allowed to go on, I think.
And the problem is when it functions, when to stop in these malignant diseases. Because I have a Langerhans cell sarcoma, and she's very well since 6 years ago, and I don't know when to stop the dabrafenib, because she's at school, she's a very nice girl, but I don't know when to stop.
I would be in the same line as you, and probably I will not stop. Maybe can't 10 years. Maybe when she would be teenager, and you will let your colleagues.
I am very interested in the work, the idea of Dimitri, because we have really the patients with risk LCH in the first 8 weeks who suffer, who have the high risk to die, and maybe we should think about it, maybe for high-risk patients to start the target therapy at day 0. What do you think about it?
Sorry, Jan?
Okay. Hello.
Jan?
Yeah.
You be careful, because you have the virtual audience. Dimitri is over there, so he's connected online.
Ah, hello, Dimitri.
So I was, as Jorge was mentioning him, he's online. Dr. Itziar Astigarraga is also online.
Oh,
she also wants to make questions. So I don't know if you can see us, but we are all online here.
Internet. So Dimitri, are you here? Can you listen? Can you speak?
Yes, I can. I don't know if you can hear me, but I can speak. Hello.
But so I think that I wait the publication of your study, Dimitri. I hope it will be soon. But I think the question is still a question, I think, because we don't know. As far as I know, it's a small study, and we need to demonstrate this. Probably the question is, what is the selection of the patient at the start of the treatment? But in all cases, I think that starting with vemurafenib or MAP kinase inhibitor for a very severe presentation of LCH in young babies is probably a good approach compared to classical therapy. But it's only a part of the question. The main challenge is to cure definitively LCH, meaning that stopping all treatment and without no reactivation and no sequela. And so it's a big challenge for this group of patients. But I am sorry, but I am not conclusive on this. I think this question is open. We let a little room for the young generation to answer to this question, I think.
Mhm.
Okay.
Itziar also wanted to comment something, Jan. So
Yes, Jan, thank you and congratulations for your talk. That was very interesting and all the review was excellent, and also for your contribution in collecting the cases with targeted therapies. I have a question for you about the use of targeted therapy in severe and refractory cases, even in the first week with BRAF is negative. Because sometimes I feel that we don't have the best techniques just to detect the BRAF mutation in some patients. So I would like to ask you if you think that we should use the targeted therapy in babies with refractory disease in the first weeks. What do you think, Jan?
I completely agree, because for logistic reason, you may have not the result, the BRAF status very soon. And even if statistically there is a link between the risk organ in young baby, it's not enough to decide therapy. And the option in this situation would be to propose a MEK inhibitor, so like cobimetamib or tramatamib, and you have the advantage to cover all the kind of mutation, and so it may be an option. And we have discussion, I think, with also ECO group about such approach. The approach, there is a protocol which want to validate the Russian approach, I think the Rogachev approach. And there is also some discussion about the possibility of a randomized study to first line randomize the MEK inhibitor. Also to answer to your worrying Itziar. And maybe it's probably the best way to control the disease and to start a treatment. And because sometimes you have no time to have all the information and take a clinical decision.
And the second question is about the neurodegenerative disease. And you said that it's better to start prompt as to start early the targeted therapy. But how? What is early? What do you think? Because we know that sometimes the radiological findings keep stable for a very long time, and so we are not able to treat just the radiological change, but it's difficult to detect the clinical symptoms. So what is your recommendation about the start of therapy, the targeted therapy in the disease?
It's a very critical question, Itziar, of course, and I have not to answer. I just can say what we are proposing in our group in France. We for classical neurodegeneration, meaning the patient with a DI and neurodegeneration later, and usually because the DI you have a MRI and you have a neurodegenerative feature, but without symptoms. In such case, we propose to start the MEK inhibitor only if there is minor symptoms, meaning that the patient have some school difficulty or some walking difficulty, and any difficulty, but clinical difficulty, not on the MRI. Maybe we are wrong, but it would be more convincing to improve a clinical situation than only to improve MRI. But I have no the definitive solution.
No, I agree, and also I think that we should start just the mild clinical symptoms, but I think that there are other groups that are starting very early, and I don't know the best way. So thank you.
And do you perform neurofilaments in LCA?
Yes, but I was so long, my presentation was so long that I have not present these results about neurofilament. But it seems that according also to Jan-Inge Enter team and the Swedish team, that neurofilament can be used to detect, yes, very early neurodegeneration. But this should be validated, and but I think it's a good. It's not technically, it's not so simple to do it. It's costly because it's about 80 € the test, and but it should be interesting to do that.
And there is also another question here in the virtual audience, if you can answer, Blanca.
Yes, I'd like to know, yes, thank you. I'd like to know if you have a lot of patients with neurodegeneration and psychiatric disorders, without ataxia, without other things, only psychiatric problems.
I think we have some, clearly, yes, we have such presentation, and I think I have no time to develop a lot on this aspect, but the clinical range spectrum of neurodegeneration is huge. We have some patients with addiction, I think, very strong addiction and mild motor impairment, and but strong cognitive limitation. We have some patients with so-called schizophrenic symptoms, and so we have some I don't know the name in English, errance, comment dire, errance. Il y a des patients qui sont des fugueurs. Si. But the spectrum is much larger than classical neurological symptoms, and it should include some psychiatric symptoms. And for the family affected by around this patient, it's a challenge to contain the children or the young, or usually it's a young teenager with such a kind
That's
of.
right. Young adults or so. Thank you.
Okay. Well, I feel you are very tired. We can ask you for many hours. So, if you are ready, we stop here. The people present here, we are able to take a lunch. No, not by Zoom. Okay. Okay. Thank you so much. Thank you so much. Yes. Thank you so much. Gracias, Jorge. No, no voy a ser sincero.
Guido, Guido,
A usted. Porque tenía que
Guido,
Tenía que hacer todo.
Claro. Pero bueno, siempre tiene razón, Jorge. Siempre tiene
Guido.
Bueno, Fer, muchísimas gracias.
Comentale a Jan que estaban eso, conectados también desde Perú, desde México, desde Colombia, de Panamá.
Mucho ruido.
Habían. Bueno, dale, hablamos.
Un abrazo grande. Gracias por todo.
Abrazo. Chao.